Hi, my name is David Lockington and I'm a consultant ophthalmologist based in Glasgow. Welcome to the early afternoon session of this Scottish National Ophthalmology Research Day. You will have already heard this morning of significant research which has occurred in Scotland, supported by grants and partnerships. However, the effort required to achieve major research can be quite off-putting, particularly if you're an ophthalmology trainee in a scheme which rotates you around every 6 months and often to different locations. I'd like to thank Roshini for the invite to showcase some of our research success. I have invited a selection of our excellent ophthalmic trainees to share their completed research projects, which have all been presented at national meetings and are in the published peer review literature. Their hard work is testament to the fact that there still exists a space for a clinical question to be asked and addressed through personal interest and dedication to research. That's what keeps the day job interesting, as we seek to inspire engagement in research despite our limited resources. All these projects are practically relevant, topical, useful, and when engaged with, can improve the clinical care our ophthalmology patients receive. And to me, that is the best impact factor which exists. So I hope you enjoy the following presentations. We will have a short time of question and answer at the conclusion of the videos if the Wi-Fi keeps up to it. Thanks very much.
Hello, everybody. I'm going to be introducing the talks as I think David's been blown away in the hurricane. So the first person that's going to talk just now is Sarah, who is a staff nurse at NHS Lothian, and she's going to be talking about ocular surface disease in patients attending virtual glaucoma clinics. Thank you.
Hello, my name is Sarah Donaldson. I'm a staff nurse working in NHS Lothian. I recently completed the University of Edinburgh Primary Care Ophthalmology Masters, and I'd like to thank Professor Sanders, who has invited me to present the results of my final year project. I would also like to thank Supervisor Dr. Malcolm and Dr. Ellis for her support throughout the course. The title of my project was Ocular Surface Disease in Patients Attending Virtual Glaucoma Clinics. Ocular surface disease is a term used to describe a group of disorders of the tear film, including dry eye disease. Symptoms include red eyes, ocular discomfort such as grittiness and visual disturbance, particularly transient blurring of vision due to disruption of the tear film. As you can see from this next slide, there's a high prevalence of this with ocular surface disease in patients, especially glaucoma patients. 38% use artificial teardrops, and older age and use of multiple glaucoma medications increase risk. In 2017, the findings of the tear film and ocular surface dry eyes workshop were published. Ocular surface disease is a major reason for poor adherence of glaucoma treatment and is under-recognised and poorly managed in glaucoma clinics. Patients with glaucoma are increasingly seen in virtual clinics, and this is often like a factory line seen in this picture. If patients are not seen face-to-face, how do we identify ocular surface disease? The aims of this study are to determine how common ocular surface disease is in patients attending virtual glaucoma clinics. Investigate factors associated with ocular surface disease, for example, severity of glaucoma, duration of glaucoma, number of glaucoma medications, preserved or preservative-free. So, what methods did I use? Well, I had a survey of 50 consecutive patients attending virtual clinics. These were asked to complete the ocular surface disease index, 12 items graded 0 to 4, with a positive result of 13 or over. All these patients also had visual field testing and OCT. As you can see from the red line across the board here, that there were about 6 questions that were related to vision. This can also be related to glaucoma. So looking at the results, the average age was 73, with 54% being female. Duration since presentation was 7. So the total ocular surface disease index was 10.1, with different subscales underneath. Looking across here at the mean deviation, You can see that it's increased on the right-hand side, and underneath is a lovely pie chart, and you can see 70% of these people are using preserved drops. So on this page, it shows you the results of the total OSDI subscales with the vision subscale, ocular symptom subscale, and the environmental triggers subscale. So the next thing I did was to look at what factors are associated with worse ocular surface disease index scores using a regression analysis. The only factor associated with worse OSDI score was glaucoma severity, but it was not associated with the OCDI once vision-related questions were removed, ocular symptoms subscale. This is a study done by Matthews, which is really interesting. It's showing you the ocular surface disease index score increasing along with the severity of glaucoma. But if you look at the light grey parts of this, it's to do with vision-related subscore questions. So let's discuss some results. The dry eye workshop recommended diagnosis of dry eye based on an abnormal OSD questionnaire score and the presence of at least one clinical sign of dry eye. 15 of 50 participants had an OSDI score greater than 12. The prevalence of OSD in these attending virtual clinics was lower than previous reported in other glaucoma patients, and lung actually found 59%. This is likely due to the characteristics of the patients selected as appropriate monitoring in a virtual clinic. This previous study shows that dry eye is more common with greater numbers of medications. Other important aspects of my study were that the ocular surface scores were significantly high in patients with more severe glaucoma. This could be due to the old age or greater number of glaucoma medications in this group, but in this study this was not the case. This finding was due to worsening vision-related subscale with worse glaucoma, and 6 of the 12 questions of this OSDI relate to visual function, which may be affected by glaucoma rather than the OSD. It is therefore not surprising that there is an association with worse OSDI scores and glaucoma severity. So, my limitations. I only used a questionnaire. There was no slit lamp examination, and this is not done in virtual clinic. Quite a small number, and a small number using preservative-free drops. There was no control group and only one centre. Looking at the Canadian Glaucoma Society survey, 100% agreed that comprehensive management of OSD could improve quality of life, with 97% agreed it could lead to better glaucoma outcomes, and only 22% agreed that OSD is presently being adequately managed in glaucoma clinics. Conclusions. So, ocular surface disease has a negative effect on quality of life, affecting ocular comfort, visual performance, and general health and well-being. Ocular surface disease was less common in patients attending virtual clinics than reported in other glaucoma groups. We may be doing a good job selecting the patients appropriate for the virtual clinic. Ocular surface disease is not a good tool for use in glaucoma. But the dry eye questionnaire is probably better as it has questions focused on ocular comfort. I'd really like to say thank you very much for listening to me. I've really enjoyed giving you this presentation, and thanks to Dr. Tej Malcolm for supervising my project.
Thank you very much, and sorry that I'm late to join us. John, is there anything you'd like to say before we introduce the next speaker?
No, thank you for coming back.
As always, John.
Oh.
Thanks so much. So we'll get some questions at the end if that's possible. We're now going to have 4 presentations from trainees from the west of Scotland about various projects they have done where a clinical question has been asked and they've tried to get the answer. So first up, we should have Alasdair Simpson, who's going to talk to us about the cost, capacity, and oh no, I'm being told Nicolás is next. Now I don't know what Nicolás's presentation is, so John may need to introduce that.
So Nicolás,
go for it, John. I'll step away, John. You go for it.
I'm going right. So Nicolás has. Can we see me? No. Let's see. Sorry. All right, I've managed to share my video at last. So Nicolás has chosen an extremely long title for his talk, so I'm going to simplify it to looking at 2 surgical techniques for the treatment of Fuchs endothelial dystrophy, a systematic review and meta-analysis.
Hello, I'm gonna talk about the comparison of 2 endothelial keratoplasty techniques in the treatment of Fuchs endothelial dystrophy, and this is a systematic review and a meta-analysis. This research was undertaken as part of the final year of the CHM in clinical ophthalmology at the University of Edinburgh. I want to thank Professor Sanders and Heather for the opportunity to present at this forum. Fuchs endothelial dystrophy is characterized by dysfunctional endothelial cells and descendant membrane, which leads to corneal edema, that in turn leads to a poor visual acuity. This dystrophy is the leading indication for corneal transplantation in developed nations. Corneal transplant has evolved from the first penetrating keratoplasty performed in 1906 to modern lamellar keratoplasties. Descendant stripping automated endothelial keratoplasty, or DSEK, and descendant membrane endothelial keratoplasty were landmarks in the history of corneal keratoplasty, and since its introduction they have been widely accepted by the international corneal community to treat corneal endothelial failure. Bossing introduced the ultra-thin DSEK, or UT DSEK, as a donor graph or planar shape with a thickness around 131 microns and the same learning curve as of DSEK. Ultra-thin DSEK has been proposed as a technique that could balance the good visual outcomes of DMEK and the low complication rates of DSEK. The main objective of this project was to compare the efficacy and safety of 2 endothelial keratoplasty techniques, the ultra-thin DSEK and DMEK, in the treatment of Fuchs endothelial dystrophy. This systematic review was registered at the International Prospective Register of Systematic Reviews, Prospero, and electronic databases were searched for randomized controlled trials. There was no publication, year, or language restriction. The databases searched were the Cochrane Central Register of Controlled Trials, PubMed, Scopus, Embase, the Latin American and Caribbean Health Science Information Database, the U.S. National Institute of Health Ongoing Trial Register, or Clinical Trials, and the World Health Organization International Clinical Trials Registry Platform. The selection criteria were randomized controlled trials that compare ultra-thin DSEK versus DMEK in patients with Fuchs endothelial dystrophy, and the data collection and analysis were done following standard methodological procedures recommended by PRISMA and the Cochrane collaboration. 7,980 records were identified through the initial database search. After duplicates were removed, 4,938 records were screened. 28 full-text articles were assessed for eligibility, and 24 full-text articles were excluded due to wrong study design, wrong comparator, ongoing studies, and wrong outcome. 7 records from 3 studies were included. The 4 individual domains: randomization process, deviation from the intended interventions, missing outcome data, measurement of the outcome and selection of the reported results of the version 2 of the Cochrane collaboration risk of bias assessment tool for randomized trials were judged as low risk of bias of all the included studies. In this forest plot, we can observe the results from the primary outcome, the best correctional visual acuity, from the comparison of the 2 surgical techniques, ultra-thin DSEK versus DMEK. Information from 160 eyes reported in 3 trials provided data for this primary outcome at 3, 6, and 12 months after surgery. The mean difference of the best correctional visual acuity at 3, 6, and 12 months after surgery was 0.08, 0.10, and 0.08 respectively. One trial provided data of best correctional visual acuity at 1 month after surgery and another study provided data at 24 months after surgery. The I-square statistic was 0%, and the chi-square test for heterogeneity was not statistically significant. Therefore, the data from these two trials were combined in a meta-analysis. The certainty of evidence for this outcome across the various trials was high. 3 trials provided information about the endothelial cell density from 160 eyes at 3, 6, and 12 months after surgery. 1 trial provided data for 24 months after surgery. In this case, there was a substantial heterogeneity between the trials. The I statistic was 63%, and the chi-square test for heterogeneity was statistically significant, and a summary of the pooled effect estimates was inappropriate. The point estimates from the individual studies showed no difference between the 2 interventions. The results for the outcome central corneal thickness was provided by 1 trial, Matsu et al., and it was reported at 6 and 12 months after surgery. The mean central corneal thickness in the ultra-thin DSEC group was 561 and 551 at 6 and 12 months. The reported data on the DMEC group was 520 and 518. Several adverse events were evaluated. These were donor preparation failure, rebubbling, retransplantation, elevated intraocular pressure, glaucoma, cystoid macular edema, graft rejection, primary graft failure and graft displacement, posterior synechia, and retinal tear. From all of these, only rebubbling had a statistically significant difference between the 2 groups. 3 trials, 160 eyes, provided data about rebubbling, and we observed that the relative risk of rebubbling for the participants assigned to the ultra-thin DSEC group were 75% lower to those compared to the DMEC group. The certainty of evidence for this outcome was downgraded 1 level to moderate due to serious concerns about the imprecision, because, as we can observe, the confidence intervals around the individual estimates of effect included both benefit and harm. Some of the outcomes explored in this review encountered low reporting, substantial heterogeneity, or both, which makes the comparison across trials challenging. An editorial of the Journal of Refractive Surgery had proposed a standard way of reporting outcomes of corneal and intraocular lens-based refractive surgery. A similar standard for reporting outcomes of modern keratoplasty techniques is lacking, and it might be helpful in reducing heterogeneity and making comparisons across randomized controlled trials easier. In conclusion, there is evidence to support DMEC over ultra-thin DSEC for patients with fuchs endothelial dystrophy in terms of visual outcomes. Nevertheless, DMEC is associated to a higher risk of graft dislocation and rebubbling. Thank you for your attention, and thank you, Professor Sanders and Heather, for the opportunity to be here.
Thank you very much, Nicolás, for that excellent talk. There's an awful lot of work in that, and hopefully we'll have some questions for you at the end of this session. Our next speaker should be Alasdair Simpson, who's going to talk to us about cross-linking in keratoconus, and in particular the cost, the capacity, and the clinical implications of what we do. So if we can play that video, please.
Hello, my name is Alasdair Simpson. Thank you for the opportunity to speak today. I'm presenting my paper. What are the visual service and cost implications of waiting for progression in young West of Scotland patients prior to collagen cross-linking? Keratoconus is a corneal ectasia characterized by progressive corneal thinning, leading to increasing irregular astigmatism and refractive myopia. The etiology is believed to be a combination of genetic and environmental factors, with several associated conditions, most notably atopy. The common mechanism appears to be related to eye rubbing, with repeated pressure on the cornea causing breaks in Bowman's layer and eventually Deschamets' membrane. Keratoconus is also known to be more aggressive in young patients before becoming quiescent by middle age. The clinical course can be varied, with aggressive cases progressing to corneal scarring, eye drops, and even perforation. Previously, the only direct treatment was corneal transplantation. However, collagen cross-linking has established itself as the primary treatment to arrest progression of keratoconus. This technique induces cross-linked bonds to form in the collagen of the cornea by exposing riboflavin-soaked stroma to ultraviolet light. This results in increased biomechanical rigidity of the corneal stroma. Thus, the treatment acts to stop the progressive thinning and deformation of the cornea. This preventative treatment should be performed before excessive thinning has occurred, as a central corneal thickness less than 400 microns can lead to endothelial damage by UV light. The procedure involves stripping of the epithelium to expose the corneal stroma, meaning significant pain in the postoperative period and a risk of infective keratitis. Other known complications include intraocular inflammation, dry eye, and increased corneal scarring. The current treatment paradigm is that patients referred with suspected keratoconus attend for slit lamp examination, retinoscopy, subjective refraction, and pentascan topography. Patients are then monitored for progression of disease. When progression is documented, they are listed for collagen cross-linking. But in young patients in whom it is known that the disease is often more aggressive, is watchful waiting harmful? This led to the aim of our study, which was to model the real-world, clinical, financial costs, and service capacity implications of waiting for progression in young patients with keratoconus. We identified all patients attending the early keratoconus clinic in Gartnavel Hospital, a tertiary referral centre for the west of Scotland, from the time the clinic was set up in 2015 in 2009 until in 2019. We identified all patients under the age of 21 and those with at least a year of follow-up. 76 patients were identified with 142 eyes diagnosed as having keratoconus. The median age of this group was 18 and the youngest aged 14, with almost 3/4 of the patients being male. At first review, 6 patients already had central corneal thicknesses too thin to be suitable for cross-linking. During the study period, 60 eyes of the original cohort demonstrated documented progression. However, one of these developed a cornea too thin for cross-linking, and 3 refused treatment, leaving 56 eyes, or 39% of the original cohort, going on to receive collagen cross-linking. As you can see from this table, it demonstrates those that received collagen cross-linking and the changes that occurred to their visual and topographic features, from time of presentation to prior to collagen cross-linking to post-collagen cross-linking. To draw your attention to the change in subjective refraction, there was a mean increase of over 1 diopter cylinder. There was a mean loss of 13 microns of corneal thickness and almost a whole line of reduction in best visual acuity. The rightmost column shows these features after collagen cross-linking. As you can see, that for the most part, this treatment prevents further progression but does not reverse the damage of keratoconus. With regards to service implications, these patients waited a median of 40 weeks from first appointment until procedure. These 42 patients attended for a total of 196 appointments prior to their first eye being cross-linked. Considering that if these patients had all been listed for collagen cross-linking at time of their initial appointment, rather than waiting for documented progression, this could have saved 140 additional appointments. In our health board, an appointment is estimated to cost £135. Avoiding these unnecessary appointments could therefore have saved the board nearly £20,000. This is likely a conservative estimate given the relatively labour-intensive keratoconus appointments as described previously. However, 3% of our patients did go on to develop complications, to developing bacterial keratitis. This study raises the question, should we now consider proceeding to collagen cross-linking in all patients with keratoconus at diagnosis rather than waiting for documented progression? This certainly would have provided considerable cost and capacity savings. It would have also prevented the increase in corneal astigmatism and lost visual acuity consequent by delaying until progression had been documented. However, assuming each patient had just one eye cross-linked, this would have meant 28 potentially unnecessary cross-linking procedures with its own service burden, along with the risk of complications to these patients. We also found that those who went on to receive collagen cross-linking had more advanced disease at the time of initial presentation. Thus, this study may not validate a wholesale shift in management for young patients with keratoconus, but highlights the need for further research to identify the patients at greatest risk of progression to avoid damage while waiting for progression. Thank you for your attention. These are my references.
Thanks very much, Alasdair. That's a fascinating subject and, as you know, quite controversial, so we might have a good chat about that later. Now, on my list, I have Mariam Shah as the next speaker, but I see Jonathan Nairn's video was teed up. So this is the exciting jeopardy of online symposium. So I look forward to seeing what Django's going to play for us as they decide what to do. Now it's Mariam next. As they said to, please do write some questions in the Q&A for our speakers so we can put them to them. Otherwise, you're going to have to listen to me for 15 minutes. So Mariam Shah is our next speaker. And again, she's addressed a question which I asked a number of years ago as part of my training. This is about STIs in the presenting an eye casualty and the benefits of a shared care approach.
Good afternoon. My name is Maina Shah. I'm an ST3 ophthalmology registrar from Glasgow, and today I'll be talking about ocular sexually transmitted infections and the benefit of a shared care approach. The background to this is that the World Health Organization estimates more than 1 million sexually transmitted infections are acquired every day worldwide. In 2020, 374 million new infections were recorded, which included chlamydia, gonorrhea, syphilis, and trichomoniasis. The majority of these infections are asymptomatic, so many patients do not know that they have an STI. There is always risk of ocular infection by autoinoculation or direct exposure to infected genitourinary secretions. The gold standard management is identification of the STI, rapid systemic treatment with antibiotics, a full sexual health screen to check for any co-infection and contact tracing, and then follow-up consultation to ensure treatment course is completed. In 2007, the NHS West of Scotland Virology Centre included chlamydia testing into its ocular 4-in-1 multiplex PCR assay. This meant that many more patients that were routinely getting sent for conjunctival swabs were coming back positive with ocular chlamydia. We published an audit from data collection in 2008 after the initiation of this test, which showed that only 25% of the positive ocular chlamydia patients were attending and completing sexual health management, particularly when the ophthalmology department initiated treatment. A shared care approach was then set up from this audit, which created a network between ophthalmology, virology, and sexual health, including the appointment of a designated sexual health officer to address these clinical issues. So here is a map of NHS GGC's shared care network, where the majority of swabs, just because of the location of our acute referral clinic being Gartnavel, is sent to the virology centre based at Glasgow Royal. If they get a positive result, they will then send a letter or a notification to the Sandiford Sexual Health Service, where the sexual health officer will pick this up and contact the patient to inform them of the result and bring them into the clinic to initiate treatment. Our doctors are also chasing their own swabs, and they will also touch base with the patient. This led to a 10-year review of a shared care approach in the management of ocular chlamydia infections, where our aim was to compare the recorded clinical management with local standards that were set by the previous audit to see if lessons and solutions identified previously were being followed. So our methods included a 10-year retrospective service review from January 2010 to December 2019 to assess the efficacy of the shared care network. Patients were identified from the shared care database, which receives the electronic copies from the Virology Centre of the positive ocular chlamydia results. The parameters that we looked at included documentation of communication of diagnosis to the patient, honoured referral for complete STI assessment to the Sandyford, appropriate treatment being given, sexual health screen being carried out, management of any concurrent disease, and follow-up of sexual contact tracing. For our results, we've identified 86 patients in the 10-year period, 49 of which were male, and the median age was 23 years. Ophthalmologists initiated treatment for 37 of these patients, so 43%, prior to onward sexual health referral. 5 of these patients received suboptimal treatment, either in dosage or duration, and 15 subsequently failed to attend the sexual health services for partner notification. In terms of sexual health involvement, 49 patients, so 57%, attended the Sandyford Clinic. 25 of these patients had genital chlamydia co-infection, and 98% received adequate systemic treatment. All who attended the sexual health clinic were offered full sexual health screening, and 46 or 93.9% completed partner notification. So the conclusion from this project showed that the shared care approach more than doubled the proportion of ocular chlamydia patients attending the sexual health service over the 10-year period. Previously it was 25%, and now 57% attended the Sandyford Clinic. There is evidence that shows that ophthalmologists could defer treatment to the sexual health clinic for more effective and complete ocular chlamydia management. There are obviously challenges involved, including non-attendance, inadequate treatment being given, and the incomplete contact tracing. We recommended a multidisciplinary approach to best manage the ocular chlamydia cases identified following ophthalmic testing. So, one about Neisseria, which is another very common STI. The rates of Neisseria gonorrhea infection in the UK population has definitely increased over the last 5 years. So we've had a 61% increase of the cases in Scotland. And traditional treatment teaching normally advises that ocular gonococcal infection commonly affects the cornea, causing corneal melting and perforation within 48 hours. It can be argued, therefore, from this traditional teaching, that the subset of patients with gonorrhea are a higher ocular risk group, and we have no shared care pathway within Glasgow. This led to the 5-year review of ocular Neisseria gonorrhea infections presenting to the ophthalmology departments in GGC, and this was led by my colleague Laura Butler. This included a 5-year retrospective review of the ocular gonococcal cases in NHS GGC, where a diagnosis of Neisseria gonorrhea was on microbial culture and not PCR. Therefore, these swabs go to the microbiology labs rather than the virology labs. We looked at the clinical features, management, and sexual health involvement in these cases. So the results from this study was that there were 15 cases identified over the 5-year period. 80% of the cases were male, and the average age was 26 years old. The common presenting features from this group were purulent discharge, identified in 93% of the cases, hemorrhagic conjunctivitis in 67% of the cases, and preseptocellulitis. Corneal involvement was documented in 5 cases, with marginal ulceration in 1 of these cases. None of the patients had corneal melt or perforation. The most common treatments were systemic antibiotics, including IV ceftriaxone or IM ceftriaxone, all with another antibiotic. Sexual health involvement from the clinic were all patients were referred or recommended to attend the sexual health services. 7 or 47% of the patients did attend, and 100% of these patients who did attend received complete STI testing and contact tracing. 3 of these patients had systemic treatment initiated or changed, and 1 patient had concurrent syphilis infection identified. So the conclusion from this series confirms that purulent conjunctivitis and preseptocellulitis are the main presenting features of ocular gonococcal infection requiring hospital review. Early identification with appropriate systemic antibiotics treatment avoided corneal melting in this cohort. The need for a shared care approach could be argued in this setting as well, as concurrent STIs were identified and/or treatments were changed in 4 out of 7 of the patients following sexual health review. We therefore recommend a shared care approach between ophthalmology, microbiology, and the sexual health services to effectively address all management issues. Thank you for listening to my presentation, and if there are any questions, I'd be more than happy to answer them.
Thanks very much, Maina. There's a fair bit of work in there, as we both know. We look forward to discussing that later. Our third speaker is going to be Jonathan Nairn. And if you, like me, have had the problem of urgent referrals in a system with very little capacity, this may ring true to you. So Jonathan's going to talk to us about the question, what is an urgent cataract?
Good afternoon. My name is Jonathan Nairn. I'm an ST2 trainee working in Glasgow. This project was based on our regional cataract referral pathway. The work was presented at the Scottish Ophthalmology Club in spring 21 and it won the Best Quality Improvement Prize. It was also presented nationally at the UKISCRS and internationally at ESCRS meetings. The work was supervised by Dr. David Lockington. There's no conflicts of interest to declare. So, remobilisation plans related to prioritising clinical needs were published by the Royal College of Ophthalmologists in response to the SARS-CoV pandemic last year. The document they published specified 2 categories of urgent cataract referrals, and these are displayed here in the slides. However, in Scotland, there was no guidelines published for primary care services or community optometrists as to the urgency of a cataract referral, and this creates an obvious issue at times of limited capacity or theatre access. In light of this, our audit aimed to evaluate the subjective and objective information contained within the referrals compared to national triage guidelines. Was there enough clinical information for clinicians to make safe prioritisation decisions? So we retrospectively examined 2 years of clinical records and identified 128 urgent cataract referrals. These were submitted to our department at a rate of 5 per month, both pre and post lockdown 1 measures. Analysis found a significant lack of clinical information. 46% of referrals were missing one of either a visual acuity, a refraction, or an intraocular pressure. And although we did identify priority subgroups based on the Royal College guidelines, these were a minority, displayed in the tables below. The majority of referrals, 80%, had visual acuity better than 618. And over half of referrals had visual acuity better than 612. Referrals often included personalised information describing important individual circumstances, such as main carer. However, 53% of referrals with subjective comments fell out width of the college triage guidelines. And almost half of referrals, 9 of 21, that mentioned a driving concern had visual acuity better than 612. Though we identified a priority subgroup, this audit also demonstrated a variability in referral behaviour and conflict that exists between patient expectations and other stakeholders. Conflict particularly for clinicians, in that NICE guidelines are clear that surgical decision making should be multifactorial, shared with patients, and not solely based on a visual acuity. The Getting It Right First Time report and other redesign plans make use of and promote patient surgical decision-making aids. But these aids assume that the correct patients are being identified in the community, and this is made more difficult without the correct clinical information. In conclusion, our study demonstrates variability exists in the judgment of urgent. If all referrals become urgent, then none will be urgent. It would be helpful for ophthalmic governing bodies to publish guidelines specific on this issue to primary care services and community optometry. If this does not happen, subjective information or criteria will continue to be applied. And this makes it even more difficult to identify patients at risk of harm in times of increasing demand. It also leads to confusion for patients who are faced with long waiting times after being told that a referral is urgent. Thank you very much for your attention.
Thanks very much, Jonathan. The punchline, if everybody becomes urgent, nobody will be urgent, is so important as we go forward with the capacity issues in our services based on the government guidelines. I wonder if, like me, you don't like being told what to do. And sometimes when you get a referral saying microbiology say you have to see this patient, you sort of say, well, really, do I? And this was the basis for Mariam's talk on what do we do with these positive fungal blood cultures. And so hopefully we can see this talk next.
Good afternoon, everyone. My name is Mariam and I'm a trainee in the West of Scotland Deanery. Thank you for the opportunity to present here today. I'd like to present our study about screening for intraocular candida in NHS Greater Glasgow and Clyde. This project started off as an audit, but did result in, or did contribute to a change in guidelines and subsequent practice, both nationally and internationally. Some background first. Systemic candidemia is a severe disease associated with mortality rates ranging from 35 to 60%. This life-threatening complication is associated with prolonged hospital stays, long lines, immunocompromised status, and IV drug use. The prevalence in Scotland is quoted to be 5.9 per 100,000 per year. Along with the rest of the world, this prevalence does seem to be increasing. Ocular involvement, fortunately, is rare. Historical studies have found that there are associated ophthalmic signs in 28% of cases examined. This number has been reported to be as high as 45%. However, the ophthalmic findings in those papers were non-specific. In 1994, Donoghue et al. Classified ocular involvement as either chorioretinitis, describing distinct white lesions in the retina, or endophthalmitis, with vitreous involvement. As patients with intraocular involvement can be asymptomatic or more likely be so unwell that they're nonverbal, fundoscopy screening was recommended by the Infectious Diseases Society of America in 2012, our TRUST guidelines also in 2012, and by the College Guidelines in 2017. So in this audit, we set out to answer 3 questions. 1. What is the prevalence of intraocular candida within NHS Greater Glasgow and Clyde? 2. Are patients being referred and having dilated fundoscopy as per the recommendations? And 3. Should all patients be referred for fundoscopy? So we did this by obtaining a list of all the fungemia positive patients in NHS GGC over a 2-year period. Then we retrospectively reviewed EPR and case notes, specifically looking at the patient's demographics, candida species, treatment of systemic candidiasis, whether they were referred to ophthalmology or not, the ocular examination findings, and the outcomes for the patient. So onto the results. Over the 2-year period, there were 258 positive cultures obtained from 168 adults. There was no gender predilection and a mean age of 62 for the patients. Candida species accounted for 96% of those cultures, mostly Candida albicans and Candida glabrata. As expected, all patients were on systemic antifungal therapy by the medical or ICU team that they were under. Of the 168 Candida positive adults, only half of the patients were referred to ophthalmology for dilated fundoscopy. In red here, you can see some of the reasons for the patients not being referred, including deteriorating health or the patient passing away. In approximately half of those not referred, however, that's about a quarter of the total number of patients, there was no documented reason. As for those that were referred, two-thirds of the patients were well enough to come down to clinic to be examined on a slit lamp, whereas one-third were seen by the bedside. Of note, only 3 patients were documented to be non-verbal. Of the 84 patients who were screened, only 6 patients reported symptoms, 5 of which with blurred vision and 1 with floaters. However, none of those patients had signs of intraocular candida. When looking at the clinical findings that were described, approximately 1/3 of patients had non-specific findings such as diabetic retinopathy, macular degeneration, cataract, and other things. Only 1 patient had signs consistent with intraocular candida, classified as chorioretinitis. Of note, this patient was asymptomatic, and after a week of systemic antifungal treatment, his fundal appearance did improve. Unfortunately, he did not attend further follow-up. So, going back to our questions, we calculate from this audit that the prevalence of intraocular candida in NHS Greater Glasgow and Clyde is 1.2%. But this is probably an underestimate, as it excludes those that were very unwell, those that passed away, and the 27.5% that were not referred with no documented reason. Looking at our third question, it's worth at this stage considering the WHO, or the Younger and Wilson Principles of Screening, which were first published in 1968. These principles have been updated in a 2018 consensus article, and despite being around for over 50 years, they're still driving decision-making for screening programs internationally. So based on the data that we have and the literature that's out there, we can try and answer our third question. There are strong arguments to continue screening, namely that this is a blinding condition. Patients can be either non-verbal or asymptomatic. However, there are counter-arguments, both in the literature and supported by this study. The prevalence of intraocular signs is very low in patients with systemic candidemia, and the ocular penetration of the newer generation of antifungals, such as the azole group, is very good, which suggests that systemic treatment is usually sufficient to treat ocular candidiasis. Certainly, there's no evidence that Candida chorioretinitis progresses to Candida endophthalmitis while patients are on systemic treatment. The high mortality rate, coupled with the financial burden of screening, also raises the question of whether screening is cost-effective. So to conclude, this retrospective observational study shows that there is a low prevalence of intraocular candida in NHS Greater Glasgow and Clyde. Based on this study and the supporting existing literature, our trust guidelines have been changed in accordance with the college guidelines, which were updated in 2020. The guidelines now recommend that screening should only be performed on patients who have symptoms or those who are non-verbal. More recently, the Infectious Diseases Society of America and the American Academy of Ophthalmology has also re-evaluated the literature on the subject and have updated their recommendations to match the college guidelines. Thank you for your attention.
That was lovely talk, Mariam. I don't think she's actually with us today. I'd invite the panelists who are available to switch their cameras on so I can see who we have. So we've got Nicolás, welcome, Alasdair, and hopefully Mariam is going to join us somewhere. I think all the presenters should be congratulated because as far as I see, you have asked a clinical question, you've gone away and looked at the literature, and now you've shared your answer. And that is what the fundamental inquiring mind is all about. I have a couple of questions for you, and then there's some from the audience. I'm going to start with Nicolás, if you don't mind. Nicolás, welcome. Great to see you. My question to you is, based on your work, When would you do a DMEC and when would you do an ultra-thin DSEC?
Hello, David. Thank you for the question. I think it will all depend on the clinical scenario. I think if a patient has a vitrectomy, DSEC would be a better option. And if the eye is without any prior surgery, I will choose DMEC.
Yes, it's a technical discussion, isn't it, in terms of how to actually bring the tissue safely into the eye and position it?
Excuse me, I didn't hear you.
It's to do with the mechanics of putting that piece of tissue in the eye.
Yeah, sure, yeah. With an eye with the vitreous, we're going to have an anterior chamber that is more stable, and an eye with a vitrectomy is going to be an anterior chamber without that stability.
And then my second question to you, Nicolás, is when you were undertaking your literature review, you must have come at it with your own bias and what you thought you'd find. Were you surprised by any of the articles you found?
Yes, I was really inclined toward ultra-thin DSEC. All the theoretical basis of the ultra-thin DSEC pointed to be superior in terms of visual outcomes. And we found the opposite, that DMEC is superior in visual outcomes. And well, that was a surprise. We did find a statistically difference between the two of them, but what's a bit controversial is if that difference is clinically relevant.
Correct. And also at what point in the learning curve you might be for those different procedures can seriously influence your outcomes.
Yeah, sure. DSEC, it's a technique that's relatively easy to learn, and DMEC has a very steep learning curve.
And personally, do you prepare your own tissue, or does it come pre-cut, pre-stripped from the eye bank?
Yeah, the tissue that I use is pre-cut, and yeah, from
so
the eye bank.
whenever you want an ultra-thin DSEC, that's what you get. You don't have the pressure on the day of trying to make it ultra-thin and hope it doesn't become too thin.
Yeah, that's right. That you do not have that pressure in the OR.
Okay, that's helpful. My final question to you from me, Nicolás, at this stage is you've done this great body of work, and it's obviously important not just to present it, but publish it. What doors have opened for you from there since you've done that work? Have you had collaborations? Have you had opportunities to share it? What's the next stage?
Yes, well, this was the research project for the CHM at the University of Edinburgh. And the plan for this work is to present it in other international meetings and publish it, yes.
Great. Well, thank you very much. Please stay there. I'm going to ask Mariam and Alasdair, do they have any questions for Nicolás? Or we're going to move on to Alasdair therefore. Any questions?
No. Not for Nicolás, no, sorry.
Great. So Nicolás, stay there because you can now ask questions to them and they can do nothing about it. So Alasdair, you were next. And before I get into my questions for you, there's a couple of questions in the chat. Rowley said, are there biomarkers available to predict keratoconus progression, which might help you identify who should get cross-linked at presentation? So what are your thoughts about that?
Yeah, I think that's a really interesting question. So thanks for that. In terms of biomarkers, I think I read in the question there that you'd spoken specifically about genetic biomarkers. I can't say that myself I've seen specific data relating to keratoconus. Obviously, we know it is related to genetic conditions such as Down syndrome principally, but also other connective tissue diseases, Marfan's. In terms of other biomarkers, there is some people have sought to come up with calculators that will bring together other different factors, so the patient's age, their refractive status, and their topographic features. So yes, there definitely are topographic features. If a patient certainly is approaching that 400 microns of corneal thickness, that would be a reason to go on and perform cross-linking. As we've demonstrated, patients will not uncommonly go to a point where therefore they won't be able to get that treatment. Yeah, I hope that answers your question.
Yeah, I think it's an emerging field, and it's one we would love, because your paper expertly showed the real world. Some people will get benefit, some people maybe wouldn't have, and they didn't need it based on the criteria. But it brings up the question, who invents the criteria and why? One of the questions has also come through, based on what you've said, when should a patient be referred into secondary care when they have keratoconus? What would be your thoughts on that?
Yeah, I guess any patient where there is a strong suspicion of keratoconus and there seems to be symptoms of that, so the patient is having maybe reduction in visual acuity, change in their refractive score, they can be referred in. I imagine there are guidelines as to exactly when that occurs. Dr. Lockington, you might know this a bit better than I do.
I would say there isn't, and I would say there's a historical issue here. Historically, you've got keratoconus, unlucky, nothing to do apart from contact lenses and a transplant. So while they were followed up in longitudinal studies, people weren't really interested. Keratoconus clinics shut down. And now with the advent of cross-linking, there's an explosion in these patients who have had diagnoses ignored and no intervention. And with the advent of topography and tomography through the laser correction clinics, identifying patients earlier and earlier, I think we need to catch up with the population we serve. You made an interesting point, Alasdair, about how do people present, and it's often sporadically, it's ad hoc. Mariam talked about the screening criteria. You mentioned the magic 400 in terms of a cutoff. In your reading, do you think that's a reasonable line in the sand, or do you think hopefully new technologies may change that?
Yeah, I think it's likely that this is still quite a new kind of novel technique, isn't it? There's various different forms of collagen cross-linking, and so it's likely going to be able to be done on patients with thinner corneal thicknesses. I mean, the other thing as well is epithelium on collagen cross-linking could be a bit of a game changer, particularly in terms of, we talked about the complications for patients. Well, potentially if they're epithelium on, it's going to be a very safe procedure. So I think it's something that's likely to
Absolutely, change. It is. The treatment is obviously a stromal treatment, and we have the nice guidelines for epi off. Anything else you can do as long as it's within a research protocol. And it may be nice need to catch up with that. And certainly Farhad Haifa's work is incredible to see what they are doing. I might bring in Nicolás. Nicolás, do you do epi off or epi on?
Yes, I will. Here in the institute, we do both. And we use a cutoff point of the 400 for epi on epi off. And we're starting using the sub 400 protocol.
It's exciting times, because we are offering hope to these patients that they will not need the dramas of a corneal transplant and the subsequent follow-up and complications for the rest of their life. So hopefully, you're going to do people like us out of business. What I would suggest, however, conceptually, is talking about 400 misses the point. We want to be finding these people when they're at 500, and therefore they don't need all these interventions, because cross-linking is designed to stabilize, not to miraculously improve the vision. So Alasdair will be able to share with us that this has caused a little bit of controversy raising this issue, and there's been an interesting rebuttal letter written to his project, who we were then able to respond to. Alasdair, I'm going to ask you, as I finish your section, having done this work, how has it developed you as a clinician in training?
Yeah, It's been a really interesting project. Just helps you to think critically. I think you said in your introduction, rather than just learning the medicine, learning the diagnosis, what the treatments are, to think about why we're doing what we're doing, and not just accept that. Another thing I was going to mention was just, it made me think when I get to the point of being a consultant, setting up services, things like that. This project was really made so much easier by the fact that when the early keratoconus clinic was set up, all the data has been recorded in a very standardized way, electronic records, and it really just made this project so much more viable, and the data was of a good quality. So certainly something I'm going to take forward in my own practice.
Absolutely. Start as you mean to go on, and then every patient can be a potential learning tool. Nicolás, have you your hand up? Are you going to say something?
Yes, I wanted to ask what kind of protocol, crowd-linking protocol, were you analyzing? Because there's a lot of variation in time between protocols, and that also might have an impact in the economic burden of the healthcare system.
So yeah, this is epi-off accelerated collagen cross-linking. Yeah.
Absolutely, Nicolás, you make a valid point, because the original Dresden protocol took about 90 minutes, and that's just not viable in our health service. But you could argue if it worked most effectively, it might be viable, because we never actually measure the impact in the clinic of what we do in theatre. Those are two very separate setups in terms of concept. Any other questions for Alasdair? No? Well, then we'll move on to Mariam. Mariam, thank you for that wonderful overview. In terms of the way forward, you've done that project. What's next?
So we started off with the chlamydia eye swabs, and that was a nice follow-on from the project done in 2007. And from there, we took the gonorrhea swabs and did a 5-year review of that. Now, currently, I'm doing a pediatric placement, and there's a lot of cases of ophthalmia neonatorum. So I think it'd be quite interesting to have a look at the baby eye swabs and see, we treat the baby, but also, are the parents referring themselves to the Sandiford? Because in pediatric ophthalmology, I think we're more focused on systemically treating the baby, but the Sandiford are then there to pick up the parents and just making sure, are the parents getting their contact tracing and their treatment as well. So I think that will probably be the next steps for the project.
And I'm sure your numbers will be huge for that compared to the adult ones.
Yeah, anecdotally as well, just being in the pediatric hospital in Queen Elizabeth, we've had quite a few cases in the last month, kind of 3.5 months there. So I think if that's the 3.5 month snapshot, I just don't know if I'm getting quite a busy snapshot of that, but it'll be interesting to go back and see if we can look back maybe 5 years or 10 years like we did with the chlamydia swabs to see, if we get any kind of decent numbers from there and see what happened to those patients.
I think that's a great thing to do. What you're describing is audit in action. Audit is comparing what we do to establish clinical practices. And if we don't do that, then we don't really know if we're doing good or harm. We know the first duty of a doctor is to do no harm. Was there anything shocking you came across in your work of actually people doing harm?
I don't think it was intentional harm, but when we were doing the 10-year review of the chlamydia swabs, there still was quite a relatively high proportion of patients that were getting treated in the eye clinic. And I think as the doctors treating those patients, it was, I've got something that I need to treat with systemic antibiotics. I will take initiative and I will treat this patient. But we also need to remember that there's 2 other levels of contact tracing and checking for any kind of other concurrent diseases, which we just don't have the setup to do in the eye clinic. So I don't think, you might be getting the systemic antibiotics on board, but there's still 2 other levels of treatment, which we just couldn't perform. And that was more because the doctors who were initiating that were trying to do their best by the patient, not realizing that you're missing out on the other forms of their overall management.
Absolutely. I think that's so true. And it does show you the benefits of a shared care approach. And the setup had been criticized originally because it was seen that we were not giving treatment, because our attitude was, you've got this positive result, go to this place to get your treatment and you will have thorough and complete treatment, as opposed to us giving you something in the eye clinic and then you don't turn up for your contact tracing and all the other things. But our motivation was, we are concerned about the other conditions we are missing, which we're not testing for. Some people feel that you should just give the treatment then and there. But even with people saying, oh, I'll go to my GP or I'll turn up myself to the Sandyford, there's a high fallout rate of these patients. And our attitude was, anything we can incentivize them to get this addressed can only benefit everybody.
Yeah, exactly. And, you know, I think we do need to put some responsibility on the patient to refer themselves to the Sandyford. Having said that, the shared care approach was quite good because the results also go separately to the Sandyford. So then they've got a sexual health advisor who is there, who can then call the patient up and chase them up to see, you know, book an appointment in. So it's kind of a two-pronged approach in terms of getting them to the Sandyford. We tell the patient, but also the Sandyford is there actively trying to tell the patient as well to come in to the clinic.
And it also helps with shared responsibility because, as you said at the start of your presentation, this was forced on us. Whenever the virology people changed to a 4-in-1 multiplex PCR assay, they put these things in their testing, which is great. That means if you're testing anyone for viral conjunctivitis, and you might be looking for adeno, or you might be looking for herpetic, or you might be looking for varicella, they're being tested for chlamydia, whether you realize it or not. And if you don't have a protocol in place, understandably, that's where complaints can happen, where people are being tested for things they didn't realize that was happening. So I think your work has been very beneficial.
Yeah, and I think as well, it's kind of raising awareness in every kind of generation of trainee that's come since the initiation of that when they're in ARC, when they're in the casualty clinics, that don't feel as if you need to call the patient up, bring them back and start IM or IV or, you know, any form of systemic antibiotic. There is this pathway in place where you can refer treatment to the Sandyford and they can then chase up from there.
That's great. Alasdair, Nicolás, have you any questions for Mariam? You're happy enough. So Mariam, going forward, you've obviously done this project and you're hoping to do the next project. How have you found getting involved in research has helped you as a clinician?
So I think this project in particular, I really enjoyed because I've been able to have dialogue with other specialties. So I've had dialogue with the Sandyford. They have obviously their own department and their own setup. And I think it's been really interesting to see how they receive results, how they act upon them, how they have, you know, dedicated professionals who are there just to make sure that patients are getting their own treatment. So I think going forward, it's just really interesting to see how other departments work and how we can bring the good things from those departments into our own eye clinic. So yeah, no, I think this has been a good project in that form.
Good. Now, unfortunately, I'm going to have to ask you and Alasdair the questions which are for Mariam in the chat. So, you know, hopefully you're paying attention to your talk. What is the role of tele-ophthalmology in screening for fungal cultures in the ICU? Any thoughts on that, Alasdair?
Yeah, I mean, I think that's a really interesting question. Obviously, there's been a lot of work done on tele-ophthalmology. I think for patients in ICU, it would probably still be inferior to, you know, actual indirect fundal examination, particularly to view the whole fundus. But
I'm going to stop you there, Mariam. If you're doing the pediatric rotation with the rep cam, what do you think about that?
I think that, having said that, I think that you need to look at the symptoms and still look at the entire picture, because the ret cam can be quite traumatic for the babies, having to, you know, bring it over, put proxy and get a speculum in, and having to get decent pictures. You know, I did it yesterday, and you know, they're moving around, they're crying.
But would it not have a role in ICU for a tubed patient who has had a positive blood result?
Potentially, yeah. And you can check and see how clear the view is, and and what the kind of retinal findings would be from there. It might have a view, but I think that you still need to look at the greater picture of, how likely is it that they do have a fungal endophthalmitis? Is it just because they've got a positive culture on their line and their eye is white and, there's no other concerns? But I think the RetCam has a place, especially if there are any positive findings to possibly check.
Yeah, to document.
Yeah.
Nicolás, what happens in your setup if a patient has a positive fungal blood culture? Is it automatic that the ophthalmologist needs to look in their eyes?
Yeah, well, at my setting, it is a eye hospital, so we don't have infectologists here. We do get referrals from general hospitals, and if the patient is here in the hospital, if the referral has been accepted by social work, the patient will have the full eye examination.
That's very interesting. So basically the conclusion of Mariam's project was all these people are going to be on antifungal treatment systemically anyway. Even if you find something, it's highly unlikely you're going to inject something into the eye, though some people do. And so it was almost left that if a person is able to communicate, in other words, they're not sedated with a tube in their mouth and they have no eye symptoms and there's no eye signs externally, then they don't need a fundal check until those things change. But if they're an ICU tubed, you may still need to go and see them, but that's a discussion to have. The other thing which is quite sad about our project is a lot of these people passed away because they were extremely sick before anyone got round to actually looking at their eyes, whether they wanted to or not. So that's that project. We have, and that maybe answers one of the questions, did the identification of ocular candidiasis change the patient's treatment? The answer was no. So that's one of the reasons why it's kind of not really truly screening. We have a couple of questions about Jonathan's cataract, how urgent is a cataract project? And I suppose the question comes, Mariam, is visual acuity a good measure of visual function? And can we use that to decide if a cataract should be urgent or not?
I think it's visual acuity. I think you should also look at, how their quality of life is. Is it stopping them from driving? So if it's somebody who's, maybe a carer for a parent and they're having to drive around, their vision is just below the driving standard, I feel like that should potentially be prioritized over, a 636 vision cataract where, they still have one good eye. I think it's a case-by-case situation.
It's extremely controversial. Alasdair, what do you think?
Yeah, obviously visual acuity is limited, but when you're making a guideline that's going to dictate these things, you need something objective and that can be repeatable. So I think it's the best we've got, really.
Yeah, it's very difficult because the reality is the tyranny of the urgent takes the place of the important, and everybody's eyes urgent to them. So you're being asked to do something impossible. We're not allowed to use the R rationing word, but the reality is if you put people at the top of the queue, you then push people down the queue. And if that keeps happening, particularly after the pandemic, how can you decide if someone who is elderly needs a certain level of vision versus someone who's younger who needs to drive for their work? I don't think we're set up to make those choices or decisions, particularly with the lack of capacity and infrastructure. And so Snellen is probably the best we have, as you quite rightly said, but everyone's got their own reason why they need their operation tomorrow. And therefore it's been quite difficult. So some guidelines are helpful. What you really don't want is the situation being compounded, which I've seen in some referrals, which essentially have said, this patient has early cataract, because the waiting list is really long, can you put them on the list? And that just destroys the whole setup. Nicolás, are there guidelines for cataract referral with you?
Well, the hospital is it's private, so
so everybody can come.
Yeah, we accept all the patients. So, and we also have like turn points in visual acuity. Obviously, we do not operate based on what the patient wants. They do have to have a medical indication, but the waiting list, it's about 4 weeks, 5 weeks tops, yeah.
Wow, maybe we should just put people on a plane and fly over to you. Might be more cost efficient. Yeah, I mean, we're all in different circumstances, but I thought it was important because, and I would love to be a fly on the wall in the optometrists as well whenever the patient says, can you put me down as urgent? Because as we all know, the easiest thing is just to say yes, rather than saying no because you don't want to lose the relationship. People are struggling, but the pandemic has disrupted so much. And I guess that's why some of the independent treatment centres in England and also the Jubilee in Scotland are doing well, because they can get through these people without comorbidities and other ocular conditions. And, you know, we have a massive backlog. So I think that's all the questions in the chat. Mariam's got bored and left us, so it's time to draw this section to a close. I'd like to thank all the panelists and presenters again. As I said at the start, the fact that you've asked a clinical question, you've gone away, looked at the problem, tried to put some evidence together, and then shared your answer through presenting like this, but also importantly, publishing it to get your message out there. That is the best impact factor we can have, that we are actually changing our patients' ocular outcomes. And that to me is a fantastic thing. I see Roshini's now switched on, so I'll let her speak. And thank you very much for having us. Roshini.
Thank you so much. Really impressed to hear about all the trainee initiatives in Scotland and in Glasgow rather, and David, you know, very well done for enthusing trainees. Not always an easy thing to do these days. In my day, you simply didn't progress from year to year unless you were undertaking research. So for you to have all completed these projects is very nice to see. It was also very interesting to hear John Olson earlier in the day about how he started off in diabetic retinopathy and, you know, persevered and kept going and actually made profound national changes. And, you know, you're all set to do that if you have conviction about what you're doing. Also, just to remind you actually that just simple things like the Chi number is unique to Scotland. We're the only place that has a unique number for each patient, which then relates to all the disease processes. The GOS contract extensively collates data on who they refer, who they do secondary investigations on, prescribing rates. So there's a wealth of data out there in Scotland that can be connected up and used, you know, both clinically and in terms of outcome. So because we have a little bit of time and the next session doesn't start till 3, I felt we should just spend 5 or 10 minutes concentrating on 2 things that were discussed earlier in the day, which have fairly specific relevance to trainees and allied health professionals. And that the first is Sarah. Are you there?
Yes,
Sarah
I'm
Kennedy?
here.
I just felt that Sarah should say a few words about the OTRA, which is a ophthalmic trainee research funding stream. And then if Suzanne's here, we'll talk about the other pilot funding scheme before we close this session. So Sarah, do you want to say something about OTRA?
Yeah, so we mentioned this very briefly in my earlier talk, but just to explain in a little bit more detail, this is a funding scheme that we've run for a few years now. We didn't run it last year just because of COVID, but it's funded in partnership between Santen, who are a commercial company, and the Chief Scientist Office, and with support from NHS 5. And the role of the award is really to to support trainees to develop a one-year research project within their own post. So it'll provide some protected time to contribute to conducting lead ophthalmology research. Now, we've just launched the scheme today as part of this event, and we have an application form and also some guidance information on the website, and we can put that in the chat, but also the links to that were on our earlier slides. So you can have access to that there, and I believe those will be shared. And the scheme closes on the 28th of February 2020. So just to say, we'd be really keen to have applications in from yourselves who are on the call, or any colleagues that you have that are interested in doing a piece of research. If you have an idea of something that's been discussed on the call today has inspired you to do a piece of research, this award's available to help give you a little bit of protected time within your job plan to be able to undertake that.
Yes, so this is in fact the third year it's been running, and it's been quite successful. So keep your eyes and ears peeled, and Sarah is the contact for that. Sarah is also in touch with the research managers in the 14 health boards. So if you're thinking of doing any Scottish survey or aspects of clinical practice across Scotland, she's a good contact. Then the next person I'd like to introduce is Suzanne Graham, who spoke earlier this morning from SHIP, Scottish Health and Industry Partnership. And of course, we're absolutely delighted that she has supported a new specific ophthalmic grant. Again, SHIP is across all specialities in Scotland, but Suzanne has specifically ring-fenced funding for a test pilot ophthalmology project. So I'm going to hand over to Suzanne to expand on that a little bit more.
Hi there. Hi, thanks. So from discussions with Roshini, we've been able to secure a fund of £20,000 for an innovation project. And there was more details in the presentation in my slides. But so the main kind of stipulation for this innovation project would be that it would have to involve an industry partner, and we'd be looking at something that's close to being market ready. There's Ian Livingston has done work through the test beds infrastructure around his eye testing at home. So that would be an example of a kind of innovation project that's currently happening within the test beds. So this was just an opportunity today to stimulate a bit of activity within the innovation scheme, the innovation sides of things, with that fund of 20,000. But there is future funding that will come out of the SHIP team as well for more projects with our the Catalyst Challenge that I also spoke about within my presentation, but that hasn't been released as yet. But so more information will be coming next month. We're hoping that will be launched next month, and we are looking to fund ophthalmology projects within that area as well. So if you do have an idea for an innovation project, what I would suggest you do is that you get in touch with your regional innovation hub or the test bed and have a discussion with them about what your idea is, because the hubs and the test beds have got all the experience with how to actually get these projects off the ground, what kind of governance is required, and kind of just the practicalities and logistics of really getting something like this going. I'd be very happy to be involved in those discussions as well. And at the moment, we don't really have a set process for how this £20,000 will be allocated. I think we need to wait and see what interest there is from the community. And then when we get a feel for the projects that are coming into each of the innovation hubs, depending on the volume we've got, we could then take it to one of our governance groups we've got the test bed strategy group and the test bed governance group that work across all the 3 innovation hubs. So if we do have a large volume of interest, for example, we might ask each innovation hub to prioritise a project and then take that to the governance or strategy group for a decision to be made Scotland-wide about what projects are being funded. But there is other funding coming, I would say, so there's not just that £20,000 for innovation. So I'm happy to take any questions if anyone's got any specific questions.
Does anyone on the panel have questions? Please apply, because we have to be seen to be applying so that it's renewed year upon year, and it's also potential for whatever you do to have national rule. So thank you very much, Suzanne. I think, David, I'll let you close the panel. From threatening not to be here at all, I think most certainly you've you've been the hardest working chair so far. So thank you very much.
Well, that's very kind of you, but it doesn't say very much about your previous chairs, to be honest. Anyway, this is the Hilton Euston, where the Maclusa OSI day conference is happening. So I better go back down to it. I'd like to thank all the panelists again. Some little themes have come out there, which I think is important to highlight. A lot of this is being done out of goodwill and out of good conscience. While trainees have RSTA sessions, it's very easy for them to hide and say, I'm studying for my exams. Everyone who has presented today has gone above and beyond the RSTA thing because it's the right thing to do. And you can see that in their presentations, and you can see that in the impact of what they've done. And so I'd encourage you, you don't need to have a big, massive grant. You just have to have an inquiring mind and a dedication and determination to actually deliver what your project is. And as the guys have demonstrated, that then snowballs. And some of the grant things you've suggested may well be future doors and future steps for them to walk through. So I think it's encouraging. And to me, it's what keeps the day job exciting. Every patient you see, you want to ask yourself, am I doing the best for this person? And how do you know? And you know through evidence-based work. And we have in a very small way, hopefully contributed to that. So I appreciate the invite, and I'm grateful for the platform to show the hard work which trainees in the west of Scotland and across Scotland are doing. I've been told to tell you the next session is going to start at 3. So I suggest you enjoy a tea, coffee break and have a big stretch. And I hope to see you soon. Thank you very much.
Thank you.